Christopher Wood is singing together. So just it's my specialized picture. And at the time, I discussing the one case. It's a real case, so I very worried about how to treat this patient. It's a 75 years old and no complication, good case. And 1 centimeter, very small tumor in there. And my previous doctor is treated TURBT, then T1 high grade. Then they follow the standard therapy and they treat second TUR. The T1 disease is still remaining, but the neuroendocrine variant. So his physician recommended radical cystectomy without neoadjuvant. But the patient don't like cystectomy, so he asked me to put the indication of chemoradiation. So please your hand. What do you recommend for this patient? It's a true T1 disease, but some tumor in second tier specimen, but it's neuroendocrine disease. It's a rare case. So BCG 1. Radical cystectomy without neoadjuvant. Oh, many. Radical cystectomy with neoadjuvant. Few. Chemoradiation. Others. Maybe some. Oh, chemo. Okay. I think previously you remember this case and I discussed with you together. So at the time you said chemo. And Christopher would say no radical cystectomy without neoadjuvant. So he recommended chemo and something. And this patient is coming and I checking CT again. Then tumor is a T1, it's very small and 1 centimeter, so it's gone. However, 3 lymph nodes is swelling then before CT. And I check again, then such lymph node is growing, so it's true metastasis. So our final diagnosis is T1 N3M0 and definitely neuroendocrine variant. So what do you recommend? So neoadjuvant 3 course, then if respond, radical cystectomy with extended lymph node adenectomy. Or it's a metastatic disease, so M0 but N3, so you recommend chemotherapy more than 6 course or others. So number 1, neoadjuvant and cystectomy. Oh, you have chemotherapy. Okay, have. 2 years before, everybody said Taiwan colleague and MDX said, no, it's a metastatic disease, definitely. So you should chemotherapy without cystectomy. So, but my opinion is number 1, so I think it's almost half. So this is a very good discussion case because it's a neuroendocrine variant, so we should follow the standard therapy or change to my standard therapy. So what's a variant histology? So many times you see the differentiating the squamous cell differential granular and small cell is here. And WHO criteria is right here. So definitely we should pay some attention micropapillary variant, sarcomatoid variant, because it's not common. It's a common and also it's very worse. And small cell variant is entered in others. So how frequent such a variant? So I have now chance to access to the national database of the hospital-based cancer register. This database is a government organized, so not JUA or not university. It's a government organized database. And we, such cancer cases is covered about 67% of patients newly diagnosed with cancer in Japan, so all cancer. So I access to this database from 2020 to 2015 because these 4 years is data is clean up and we can access it. And we put up the tumor in bladder, UUT, and urethra. Then in this database, bladder is about 96,000 cases is registered, and upper urinary tract 25,000 cases. So definitely in Japan, the bladder is dominant, so different in the Taiwan. But the urethra is very rare, but 650 cases registered. And interestingly, about 5% cases in variant in bladder and UUT. The urethra is completely different because female urethral tumor is many times adenocarcinoma or squamous cell carcinoma. So interestingly, in bladder and urethral upper tract is a variant is a little bit higher in female and high stage. Then what's a standard therapy or you see, and how to personalize therapy if variant history in there? Just we focus in the MIBC. Now Oyama said the standard therapy is neoadjuvant and cystectomy for MIBC. And true evidence is just published EMBARK and only EMBARK. So DD EMBARK is just a retrospective cohort study, and also GC is the same. And this is a landmark study, so it's published Grossman in 2004, and about 8% is survival rate is improved. And also JCOG is a Japan Clinical Oncology Group conducted, so Kitamura is a PI, and he randomized 130 patients. So definitely GC2 cycle is improved the overall survival. So in Europe it's a 4 cycle. In Japan the 2 cycle is enough. And 3 cycle EMBARK is too toxic. So I hesitate. I don't like to DD EMBARK. So just one reason. And then who is have a benefit from the neoadjuvant? So this paper is say now lots of molecular subtype is available, and luminal or P53 like and crowding low is no benefit. However, if tumor is a basal type, then it has only benefit from neoadjuvant. Then question is what variant is basal? So this is not my study. So one good review is published in the histopathology in last year. It said that if squamous differentiation sarcomatoid lymphoepithelial-like and small cell is basal type, and micropapillary glandular plasmatoid lipid cell is luminal, so it's not good for chemotherapy. And interesting paper is that another research is access to the National Cancer Database in USA, then pick up the T2 or 3 and N0 or N1. It's 63,000 cases, and about 10% is non-pure UC. And neuroendocrine is only 269 cases, and neoadjuvant 50%. Then so thank you. And then okay, so only neuroendocrine have a benefit from the neoadjuvant, like here. And micropapillary squamous adeno is not this. Sarcomatoid is a little better because it's a basal subtype. Then I back to my cases. My case is a T1, N3, M0 neuroendocrine, so I joined to the Taiwan conference. Then definitely everybody say check the brain metastasis, only T1, N3. So, but it's no metastasis. EP3 cycle, as metastatic disease, then check by CT, then CR. So we continue another 3 cycles, but no tumor. Then I said, please do remove the bladder. Then PT0, N0, and now 1 year no recur. So definitely we need to close follow-up. But I think that sometimes we should do radical cystectomy, but the timing is very important for such a neuroendocrine therapy. Then how about the future? Because now standard therapy is changed to, in Japan, the pembrolizumab is approved in the second-line therapy. So how about the Asian and Europe? So I have a chance to access to the Keynote 045 database, and last year I published in the JUA annual meeting in Japanese subgroup analysis. So definitely, in overall, all patients is 3 months better than chemotherapy. It's everybody know it. But the Japanese subgroup is a small number and not balanced. So median overall survival is 9.9, 7.9 versus 8.3. So it's same. However, the survival rate in 2 years, it's almost same. So if we treat in the second line Keytruda, then 27 is in all patients, and Japanese subgroup is at 27, so almost same. And response ratio is at 20 and 20, so almost same. So I think IO drug is the same activity in Japanese cohort and Europe cohort. However, chemotherapy is a little bit better than Europe or America. I'm not sure why. I think it depends on the not balanced. So who are good candidates, IO drugs? So sometimes the PD-L1 status is important, DDR is important, and also such good reviews say lymphoepithelial-like bladder carcinoma has response to immunotherapy. So now some specific variant have a response. But that information is now not too many, and it's not established. So then who is a bad candidate? So I discussed in the luncheon time, and one review say P53 inactivation or MDM overexpression or some EGFR alteration or elderly age, such a risk factor for hyperprogression. Then in colorectal cancer, the mismatch repair deficiency is a good predictor to effect for PD-1 blockage. And approved drugs have sometimes mismatch repair deficiency. And this year, pembrolizumab have approved for MSI high tumor. So that's not only colorectal, so bladder cancer, testicular cancer, prostate cancer, any kind of tumor is okay if such tumor has a MSI high. It's a covered insurance. Another interesting is that Lynch syndrome. It's a MSI unstable. So such time is a abdominal tract is a very high incidence, but not bladder cancer. It's similar to Chinese herb incidence. And prostate. And so if such a young patient have an abdominal tract, then Europe or Japan or USA, we should pay some attention Lynch syndrome or not. But Taiwan should pay attention to Chinese herb or something. So I think different etiology. And this is my final conclusion. Variant histology is definitely it's rare, but it's important to decide treatment strategy. So my opinion is it's not analyzed in only one university or one country. So I think it's a good target for this international collaboration work. Thank you very much.
Thank you for your presentation.